This is Terms of Service. I'm Claire Duffy. If you've ever gotten a scary medical diagnosis or know a loved one who has, you probably remember where you were when you got the news. For doctors, diagnosing diseases early is a huge priority. The sooner they catch an issue, the more likely they are to be able to treat it. But doctors can't know everything. And for many patients, medical issues can go undetected for a long time. In recent years, though, some doctors have added a new tool to their screening toolkit, and that's AI. AI algorithms can analyze medical tests and images and help diagnose patients faster and more accurately, potentially picking up on patterns or issues that human doctors can't. In some cases, the results are pretty remarkable. To help me understand how this works, I invited Dr. Pierre Elias to our studio. Dr. Elias is a cardiologist and the medical director for artificial intelligence at New York Presbyterian Hospital. He's worked on training these new AI models, and he's hopeful about the life-saving potential of this technology. Well, Dr. Pierre Elias, thank you so much for doing this with us.
Thank you for having me.
So you are a practicing doctor, but you are also a data scientist. Which of those interests came first for you?
I was always interested at the intersection, but for me, I had a moment where I said, I know I want to practice medicine, but I know I also want to change medicine. And so I actually took a leave of absence from med school, headed out to Silicon Valley and worked as a software engineer out there for a couple of years. And that was the moment when I realized it wasn't that I wanted to do one or the other. I wanted to do both.
You are the medical director for artificial intelligence at New York Presbyterian Hospital here in New York City. Can you explain what that means and talk to me a little bit about the kinds of things that you're researching?
Absolutely. So what that means is we develop, validate, and deploy AI technologies to take better care of patients. We've worked on a whole range of technologies, but really one of the biggest areas that we've been focused on is how do we take the best care of patients who we don't know about today? And that really has kind of blossomed into a screening program for cardiovascular disease that exists across our 8 hospitals and 190 clinical sites.
I understand there's kind of an interesting story that led you to pursue this research. Will you tell me about that?
Yeah, absolutely. This started for me when I got a call overnight in the cardiac ICU from an outside hospital. Another doctor called me about a patient who had shown up in their emergency department. And a few months prior, that patient had shown up with chest tightness and shortness of breath, but they had realized, hey, they're not having a heart attack. The only thing that we recognize is you should just go see your primary care doctor, which would be the standard of practice anywhere. A couple of months went by, and then he had those same symptoms happen again, this chest tightness and the shortness of breath. But this time, the patient was in significant distress, and they realized that he had severe valvular heart disease. So we have these different valves in our heart, and just like plumbing at home, they can get rusty or leaky, and this patient had life-threatening valvular heart disease. And I spent the rest of the night working on the patient. But unfortunately, as the week went on, he went into multi-organ failure and he passed away. And I'm convinced that if we just had a system where we could have known about this patient sooner, that patient could have gotten an outpatient procedure, and I think they'd be alive today. And it really drove home this fundamental fact that we all struggle with in medicine, which is you can't treat the patient you don't know about.
Right. So setting aside artificial intelligence for a moment, what is the general protocol for diagnosing heart disease in a patient? Like, what kinds of tools do doctors use pre-AI?
It's a great question. We have a wide range of different tests that we use in order to diagnose different forms of heart disease. So sometimes we can use an ultrasound of the heart to take a look at the structure and function of the heart. Other times we can look at the electrical signals of the heart to figure out if there's anything wrong with the electricity passing through the heart. And then we have other modalities like nuclear imaging and radiologic imaging to take a closer look at all of these different parts of the heart. But a wild thing that is true is that we don't have a screening test for the most common cause of death in the world, which is cardiovascular disease. We have mammograms, we have colonoscopies, we have no equivalent for most forms of cardiovascular disease. And the reason for that is relatively straightforward. the way that we diagnose cardiovascular disease today is either too expensive or too invasive to use at a population level. So what we're left with is oftentimes waiting until patients develop symptoms to then say, okay, it makes sense to do this test because of the cost or the invasiveness of it.
And how do you see AI potentially changing that going forward?
Yeah, one of the biggest things is a few years ago, we were really trying to understand, like, what is it that AI can do in medicine? And, the story you saw was that AI was trying to kind of approximate the level of expertise of a human doctor. And what we've really seen kind of transition is, depending on the questions you ask AI, it can actually outperform human doctors. So a perfect example is an electrocardiogram. This is when we measure the surface electrical activity of the heart. If you've watched any medical drama and you see that kind of beeping line in the background, that's an electrocardiogram. I have, as a cardiologist, read well over 10,000 electrocardiograms in my career. And from medical school to my cardiology training to practice, I was taught that there's a whole range of cardiovascular diseases that you can't detect or diagnose from an electrocardiogram. But over the last 5 years, we've built a whole range of technologies and models where we kind of ask these fundamental questions. Could we detect heart failure, valvular disease, all of these sorts of diagnoses from an electrocardiogram? And what we were kind of shocked to find is that, AI technologies can indeed do that and can significantly outperform cardiologists in detecting these diseases from a cheap test that we do, well over 400 million times a year in the world.
So right now, to get an actual diagnostic test, it sounds like, is very expensive. And the electrocardiogram isn't necessarily a diagnostic test because it could be hard for doctors to interpret, but maybe in the future it could be because AI is better at interpreting it. Did I get that right?
Yeah, absolutely. So the idea is lots of people today get electrocardiograms for lots of different reasons, whether, it's like pre-athletic screening or you have some palpitations or some other reason. The benefit of these new AI technologies is it's really helping us find that there are patients who have this cheap test who need the more expensive test, an ultrasound of their heart. And it's really creating a new screening paradigm and a new pathway for us to try and find patients with undiagnosed cardiac disease. And one of the biggest things we know is that when we find cardiovascular diseases earlier on, we're able to take care of them for a longer period of time and patients have better outcomes.
So talk me through the process of training these AI models to be able to do this kind of diagnostic work.
So the first thing you need is good data and you need lots of data. So, we have created one of the most racially, ethnically, and clinically diverse, data sets that has ever existed in cardiovascular disease. And we have data going all the way back to 1985.
Wow.
We have data from academic health systems, from community hospitals, from patients of all races and ethnicities, because for us, it's very important that the data is representative of the people we want to take care of. So we spent years kind of developing and curating a data set that we think allows us to answer these sorts of questions. And then once we've kind of trained one of these models, the next thing that's really, really important is to go out there and test it in a whole bunch of different ways to make sure it's actually safe, it's actually effective, and that it can help people.
And how do you test the accuracy of these systems? Is this something that now you're using with patients you're currently treating?
So you have to test it in a whole range of ways. So one of the first things you do is you say, okay, we have a set of patients that we've trained the model on, and then we're going to have a different group of patients that it's never seen before that you want to test it out on. So first you test it out in that totally separate group of patients from historic data. Then you go to other health systems and you say, well, did it work just at our health system of 8 hospitals or does it work elsewhere? So then we tested it, in 4 other health systems in 2 countries, and we saw, okay, it really works there. Then we ran it in the background silently for a year. So we had about 90,000 patients who came in and were getting an electrocardiogram as part of routine clinical care, and they had never been diagnosed with heart disease before. And we ran the AI model on them, and then we just monitored those patients for a year. And we asked ourselves, okay, let's see what happens as part of routine clinical care, and let's see how the accuracy of the model was. So we saw 2 really striking things. The first thing we saw was when the AI model said, hey, I think that patient has undiagnosed cardiac disease, they were twice as likely to have cardiac disease when they went for an ultrasound of their heart than all patients who were going for first-time ultrasounds. So we saw it had kind of twice the accuracy or twice the positive predictive value of routine clinical care. The other thing that was really surprising and kind of pushed us to the next stage was we saw that nearly half of the patients that the AI model thought had undiagnosed cardiac disease weren't going on to get any sort of additional diagnostic testing in the following year. And so we were saying, hey, there may be a lot of patients out there with undiagnosed cardiac disease that we need to take care of. And so that's kind of pushed us to some of the things that we're doing right now. So we are running the country's largest cardiovascular AI clinical trial in this space with the support of the National Institute of Health. So if you show up at any one of New York Presbyterian's emergency departments currently, your electrocardiogram may be getting screened by AI to see if you have undiagnosed cardiovascular disease.
Have you seen this manifest in terms of somebody comes in for a different issue, they get an electrocardiogram, and then you make the recommendation that they should have the ultrasound, and it turns out they do have heart disease? Has it made it all the way to that point yet?
Hundreds of times.
Oh, wow.
Patients who have come in for a routine knee replacement and they're just getting an electrocardiogram beforehand, and they were found to have very significant disease. Patients who showed up because there was a concern they were having a heart attack, they were not. And then we discovered, they actually had a different diagnosis. We're at the point now where there have been hundreds of patients whose care has been significantly affected by this, and numerous patients who have undergone surgeries and other forms of therapies that they otherwise would not have received.
Wow. So potentially life-saving for people, it sounds like.
Genuinely. And it's still kind of shocking to me. It really wasn't that long ago where we were wondering, does this work at all? And we're at a point now where we're running these trials and seeing a really profound impact. One of the other diagnoses that is very near and dear to me is this diagnosis called cardiac amyloidosis. It's a form of heart failure. And the story for this disease has just totally changed over the last 10 years. It used to be a disease that was missed very often, and when finally it was detected in patients, you would have to give them the bad news that there was no treatment for them.
Wow.
Just in the last few years, we've seen a number of different treatments come out for this disease. But we have been turning on an AI algorithm to try and find patients who are undiagnosed with the disease, because the holy grail is you really need to find these patients at a specific point in the disease cycle, because the medications that we can give them can't reverse disease. They can only halt disease. And so the holy grail right now for everyone is to try and find some sort of screening test for this disease.
Yeah.
And I don't think we're there yet. But at one of the world's busiest cardiac amyloid centers, we saw that we had a 20% increase in the number of new diagnoses because of this AI screening program that we've been running. And, every single one of those patients we've diagnosed, I have a copy of their scan in my office on my wall. And we're not going to stop until there's no more space in that office, and then we're going to add another office, because those people, their lives are simply changed by getting them to that diagnosis that they otherwise weren't going to.
That's amazing. So what is the future of this technology? And can AI be used to diagnose other types of illnesses? That when Dr. Pierre Elias and I come back from a short break. Zooming out from your cardiac specialty for a minute, do you see AI potentially being used to diagnose other types of diseases? Are there examples of this elsewhere that you think are promising?
Yeah, absolutely. I think there are a couple of places where AI can really make a big difference. So the first is in this idea that we kind of call opportunistic screening. So what do we mean by that? We mean, how do you find a patient who otherwise is not being considered for disease? So we're starting to see some really powerful things happening in lung disease, heart disease, and GI disease. One thing that is really on a lot of people's minds right now is this increase in colorectal cancer in young patients. And so people are asking, can we have AI-assisted or digital biomarkers to try and tell us, hey, this is someone who has some sort of profile that is a high enough risk where maybe they should get a colonoscopy at 35 or 40 instead of 45, which is kind of the current recommendations.
Right.
So there's a whole host of work that's going on right now about that. Another place is trying to bring down the cost of certain care by decreasing the total amount of labor that something requires. So there are a lot of detailed measurements that we do in healthcare, whether that's on an ultrasound of a heart or on a CT scan. And so can we make that a lot faster, simpler, and cheaper using AI technologies, so then the overall cost of doing a scan or analyzing that scan can come down as well. The last place that I think is kind of really, really exciting and super interesting is the way people are able to engage with their own care using some of these large language models. So how do we get patients to feel like they have a better understanding of what's happening with their care? And how do we just deal with all of those friction points? In 2025, it's still so painful to get an appointment booked with a doctor, to know what's happening, to have some sort of follow-up. And so we're starting to see some sort of kind of specialized large language model agents that are being created to help patients with just that care navigation process.
Interesting. I want to ask about the cost piece, because that's something that sort of has come up in my brain as you're talking. Do you imagine, especially because there's so many conversations right now about access to care and the cost of care, do you imagine that having this kind of sort of additional AI screening that might happen when you see a doctor, is that just going to happen for everybody? Or is there a risk that we move into a place where you have to pay extra to have the AI screening?
It's a really good question, and I don't think anyone has the answer. We've seen different innovation cycles, right, both in healthcare and in other industries. And oftentimes, I think what happens is you have to be willing to pay for innovation upfront. And then you have to set a relatively high bar of having that innovation prove its long-term value and then bring the overall cost of care down. And that's the most ideal thing. So what you would imagine is there may be some sort of for-profit model or, the equivalent of like Uber Black Car. And that's where you start, which is, hey, people are willing to pay out of pocket, or people are willing to pay a premium from some sort of new technology. But what you really want is then you want a layer of really high quality evidence being generated to say this is not just a nice to have, this is a need to have, and this is a beneficial use of society's resources. And then you start to see a larger swath, the U.S. government, larger swaths of payers come in and say, okay, we see how this has clear and long-term benefits to patients and to the health system at large, and then we're going to create better versions of it. The issue is that AI is constantly changing and constantly scaling, and so to try and understand, well, how expensive is something and how good is it is much more of a moving target with AI than it's been with either traditional medical technologies or pharmaceuticals.
Interesting. Is there any risk of over-relying on AI in this process?
Yeah, absolutely. There is a real question here about what is the role of different AI technologies and how do we realize that physicians, nurses, other healthcare providers are humans. And so if you are asking someone to get behind the wheel of a Tesla and you say that there's quote unquote full self-driving, but you have to be aware of everything that's going on, and for that 0.1% chance where something goes wrong, you need to be ready to immediately take over the wheel, you are setting people up for failure. So we have to start to understand what truly is the role of these technologies and what is the role of a practicing physician in the interaction with them. There's a lot of different ways to think about it. So one may be, hey, you know what? The AI agent is just totally doing its thing, and then I am just here as someone dealing with the decision it made, right? You could have what we call kind of fully autonomous AI, and those are kind of class 1 medical devices according to the FDA. And those are pretty rare, but they do exist. There's one for diabetic retinopathy, right, where it just it takes a scan of your eye, and then it makes a diagnosis, and then people are just responding to what that diagnosis is. Then there's ones where it's supposed to be more of a human-AI interaction. And there's a lot of questions as to, well, what do you want that relationship to look like? So one example could be, let's say I have a whole bunch of imaging studies that I need to read, and AI is there to help me. So one way you could do that is AI reads all of them first, and then I read them. But then I may be anchored to what AI's decision was to begin with. Another way that you could do it is maybe I read it, and then only when I'm uncertain do I ask AI. And a third way is AI reads everything, but then it says, hey, here's like the easiest bottom third, and I am like 99.9% certain that these are all negative for any sort of finding. And then you can say, great, I'm going to take a look at those, but I'm going to look at those ones more quickly and the like. So there was a really good study in Europe that was just recently done where when they read mammograms, the way it works is every mammogram has to be read twice independently by two different radiologists. And so what they said is, could we create a better system than that? So one of the ways that they thought about it was, okay, we're going to have a radiologist and an AI model read it independently. And then if they both think it's low risk, great, no problem, we're calling it low risk. If they both think it's high risk, great, no problem. But then if one of the two of them thinks it's high risk, okay, then we have the second radiologist read it.
Yeah.
And so what they saw was it not only increased the breast cancer detection rate, it decreased the total number of patients who had to come in for a diagnostic study. And you went from having two physicians reading each study to one physician reading it most of the time and then only having a second physician come in part of the time. And so those are some of the systems that we're studying right now, but give us an idea or a glimpse of what the future can look like.
Do you have a sense of which of those models is best at this point based on the research that you're doing?
I think it's so different from technology to technology and over time. The things that I really think are true is what you want doctors who are willing to learn more about the AI technologies and understand where they're good and not good and become calibrated to them. So really, in my mind, each technology is going to have to get used, and we're going to have a call to action to clinicians saying, these technologies are changing over time, and we have to engage with them, and we have to figure out what's the right way to use them, just like we do with all of the new things that we kind of learn in clinical practice year over year.
What has the reaction been from doctors to the acceleration and the improvement of AI? Is there anxiety that this technology could replace clinicians in some cases?
I think doctors are too busy to worry about having their job replaced. They're like, here, you want this job? Go ahead, AI.
Yep.
I don't think AI is going to replace clinicians in the next 5 or 10 years. I think some people are going to get really augmented by them, and then other people probably to their loss are just going to try and ignore it. The things that I tell other clinicians is you really should engage with the technology. And then the things that I tell technology companies is you have to very deeply and fundamentally understand what is the problem that you're solving. And that's what makes all the difference.
So on the patient side, it sounds like they won't be directly interacting with this kind of diagnostic AI. But I know that we're also seeing AI tools that doctors are using in visits with patients. Can you talk a little bit about those where patients may actually see the AI come up in their healthcare interactions?
Yeah. So there's, maybe two, great examples. So the first is what we call kind of ambient scribing. So anyone who's had a doctor's visit, the doctor is kind of hiding behind a computer, typing for the whole visit, trying to take notes because the documentation is something that we have made so core to the clinical process. And so now basically, a doctor can just put their phone down and then there is, a listening device that's then taking notes from that and then turning it into a doctor's note. And so we've seen a large growth of those sorts of technologies. And I think for the most part, patients like the idea that they can kind of more directly engage with their physician. The jury is still out. What is the impact on, productivity? What is the impact on the quality of the notes? All of those sorts of things. And there's always a concern that what will happen is people will say, well, great, I created this technology, I'm going to charge you for it. And then people are going to then be motivated to say, well, now you need to go see more patients. And so you have less time with them. So you really have to kind of fight against that. But on the flip side, I do think there is this opportunity to potentially reconnect with patients that doctors really, really desire. I think that's why almost all of us went into it is it's not just about the practice of science or the application of science. It's about the relationship with the patient and sitting there with them as they're going on this health journey. So that's one. Another is, as we use some of these AI technologies that are screening patients for disease, sitting down with a patient saying, hey, I think you need this scan. And then they ask, well, why? And then you say, well, because this AI model told me so, right? And what is the engagement there and how do you talk about that? And I think that is where, evidence is so important, right? Being able to talk with the patient, being like, hey, this didn't come out of thin air. What this is, a new form of study that is telling us that you're at high risk for something that we really, really care about. And, we wouldn't recommend this test unless we thought the benefits outweighed the risk. And I think building that trust and saying technology is another thing that is here to support you is a really important message that we can give people.
Yeah, it's such an interesting point about the AI scribe technology because I feel like we're at this place where a lot of people are a bit skeptical of AI chatbots. And so I can imagine your doctor says, can I put this AI recorder down? You're like, I don't know about that. But if it means that you get to have a more personal, connected conversation with your doctor where they're not staring at a screen, that does feel like a really positive thing.
Yeah, and health systems are one of those bastions that have really fought back against some of the traditional AI practices that you see from companies. So a lot of companies, it's like, if you're using almost any AI product and you're not paying for it, you're the product, right? Your data is the product. And so, health systems have been one of these bastions that's really fought back against this. And when they sign contracts for some of these AI technologies, they say, hey, you can't train your models on the data that we're creating and things like that, because we have such a high bar of respect for patients' data, right? And we say this is privileged, this is sensitive, and more important than any of that, like this is part of how we build trust with our patients, right? That we promise to honor that relationship, and so I think that runs very true and very deep for health systems and healthcare providers.
Something that we like to do on the show is to leave listeners with a bit of practical advice. So I wonder, knowing how quickly this technology is evolving, how important is it that a doctor actually be involved? Because I know there's this growing trend where people will just go to one of the mainstream chatbots and kind of, here, I described my symptoms. Can you tell me what's going on? It's like the next iteration of Googling, why do I have a headache? Does that worry you? Is that an opportunity? What do you think about that use of this technology?
The part that worries me is when people think that their ability to use a large language model is a replacement for a medical degree. And if you look at a lot of the different AI experts across the fields, one of the things they say, AI is not good at is learning a brand new field, right? It's good at generating ideas. It's good at generating concepts, predictions, and things like that. But it's hard for you to then evaluate, is it on track or off the mark if you don't already have expertise in it? So the thing that would be concerning to me is if someone automatically presumes that it's accurate 99% of the time and things along those lines. The places where I think it can be hugely valuable, right, is oftentimes people have these short interactions with physicians, and it's very overwhelming. And they are trying to, make sense of it and heads or tails and things like that. So one example is, you can ask your doctor, hey, do you mind if I just turn on like a voice recorder or a voice transcription during our conversation? I know that you're going to tell me a bunch of information. I know it may be overwhelming and I may not catch it all the first time. I want to just like absorb that information and then be able to learn more about it afterwards. And then using the technology to kind of ask a series of questions as to, hey, I was given this diagnosis. Can you give me a sense of what this means? Can you point me to other resources that you think are really good places to understand more about the symptoms for this diagnosis, the treatments, the outcomes, and things along those lines.
Interesting.
So using it as an agent for navigating the care process and breaking down information that is given to you by a qualified primary source, that I think is a place where it can be really, really helpful because it's so overwhelming to be in the seat of a patient. And like we all know this. It's super hard to try and navigate all of that information. And I think this can be a wonderful resource in helping people do that.
Well, Dr. Pierre Elias, thank you so much for doing this.
Thank you so much for having me.
So to recap, first, from what the research has shown so far, AI tools can be effective at screening for medical issues that might otherwise go undetected. By flagging abnormalities in tests that a human eye might not catch, these tools can help doctors zero in on patients that need a closer look. So if you hear from a doctor that AI might be reviewing your files or test results, that may be why. Next, while you as a patient probably won't get to see most of these AI diagnostic tools at work, you might start to see doctors using AI transcription tools to take notes during your visit. Finally, be careful about relying on large language models too much for medical advice or for self-diagnosis. Once you have a diagnosis from a doctor, AI tools like ChatGPT can be helpful at breaking down what that diagnosis means. But they're not always 100% accurate, and you should use them with caution. Thanks for tuning in to this week's episode of Terms of Service. I'm Claire Duffy. Catch you next week.